that is just my journey. It's going to be a personal journey and an academic journey. But I have been very privileged on this journey because I had funding, I had support, and actually I had great colleagues. So the journey isn't just mine, it epitomises the people I worked with. So, what I will say to you is, I'm not some sort of genius or I was born with some great academic capability. But what I did realise that was important, and I still believe is important, is endeavour and perseverance. And I love this quote, which is great works are performed not by strength, but by perseverance. And actually, the whole of research for me is about perseverance because many people give up. And I want to say that for me, the gift of being able to research and the opportunity to research is something that we should never ever lose as academics. But my journey started in my first year at the University of York. And I was a bog-standard undergraduate who really enjoyed much of university life, which was socialising and turning up to lectures when I could manage it. But I applied. I wasn't a well-travelled student. And I applied for a travel grant from the University of York. And they said, well, you can't just apply for the grant, you have to actually do something. So I said, okay, I would go and do some work in a hospital called Turatuma in North Kenya called Karatina. And I met somebody that changed my view of what I should be doing. And I met somebody called Ingrid Halfjord. And she was the anaesthetist at the hospital. And she came from Taunton, and she decided that she also wanted to change her life. She was very, very bright, and what she taught me was it's really important to think about the care of patients and not just actually, let's just do something today, to really consider how we can impact lives for the future. Now, it was also very interesting that she never mentioned until we decided we'd climb Mount Kenya, that she said, oh, my husband's going to come over with a couple of friends. So I said, oh, that's nice. And so Ingrid Halfjord, who's Dutch and very interesting, and her husband arrived and she introduced him and he said, oh, Nigel Popplewell. Well, I wasn't a great cricketer at the time, so I didn't know that Nigel Popplewell was a cricketer at Somerset. But I did half recognise Viv Richards and Ian Botham. And so it was a very interesting experience. It probably gave me different outlooks on life. I climbed Mount Kenya. I wasn't a great climber, but actually I managed to get up and down because I was inspired by other people that were interesting on that journey. But what I did go back to is to do my degree, and actually the one thing that I then became very interested in was the neuron. And that is the simple, the most functional unit of the brain. And what I was really interested in, how does that work? How does that connect? How important is that in our behaviours? How does it function? How does it make things good? How does it make things bad? And I really became quite involved in what would that one cell and those connections of cells do. So I did well in the end in my degree, and in my last term, my tutor came and said, the Wellcome Trust has announced that they're going to give 10 scholarships, and we would like to put you forward for one of these 10 scholarships. And I'm going to say I didn't quite know what that meant. I sort of said, oh, that's very nice. And so it was a PhD funded, and if I look at the struggles of today, I was awarded a £10,000 tax-free stipend for 3 years. But I clearly had to go and find what I wanted to do. And I thought, people introduced me and said, oh, why don't you go and look at this? There were the Iversons at Oxford, and then there was Geoffrey Gray in London. And this is sort of the components that, it wasn't all very focused. I wasn't knowing exactly what I wanted to do. So, many of you in the room, because I think we are many of us of an age, but there might be a few that don't remember this, we had payphones. So I had 10 pence, don't know what I thought I was going to do with 10 pence, but I was quite nervous, and I rang Geoffrey Gray at the Institute of Psychiatry. And I said, hello, I've been asked to talk to you because I want to go for one of these Wellcome Trust scholarships. And I said, I've only got 10p, I'm really sorry, so if you could bring me back, that would be helpful. So rang me back, and then he said, what are you interested in? And I became very nervous at this point, and I said, oh, alcohol. Okay? And I don't know why I said alcohol, but I probably, did like alcohol at the time. But strangely, he did have quite a few projects on alcohol. So he said, oh, come down and we'll have this meeting. So we went down, and clearly enough, I wasn't particularly interested in alcohol, but I ended up, at the end of about a 5-hour meeting, and that's probably when I first met Steve Mitchell here at the front, who didn't think I looked like a scientist, because I didn't. But actually, what I ended up with is a project that was about neurons. And I ended up working on a project that was, in a way, world-leading, because what we were trying to do was to look at chronic disorders, and the one I was working on was Alzheimer's. And it was, why do those brain cells die, and can we replace them? And how do we replace them? So the main project that I worked with Geoffrey, who I think probably shaped me to who I am. You had to deliver, you couldn't not deliver, and in fact, but he was a genius. And you would walk in his office and think, I'll just try and talk about something, and you'd come out thinking, really, I need to go and learn quite a lot more. I did have to go and learn a lot more because I'd done a psychology degree and I ended up having to do neurobiology. And it's also interesting that we look at the times again now. I went to Queen Square, which is the neurology centre for the country, world famous, and I sat in on the master's programmes every Tuesday and Thursday evening so that I could learn to what I was doing in the daytime on my PhD. I never sat an exam, I never paid anything, I just sat and learned all of the stuff. I'm not sure we'd let people into universities, but it's interesting how it transformed who I was. But this probably slide might look quite boring, but actually for me this is probably one of the most important things I ever did. So we took cancer cells, human cancer cells, and we had to differentiate them. We had to make them so that they wouldn't keep proliferating. And nobody at that time, and you look at everything that's out there, had actually injected. So we had fluorescent cells. And we were the first group that had put this fluorescent dye in human cells. And we worked on lesion models with animals, and so we had the hippocampus was clearly the area that is part of the memory process, and so we actually transplanted these cells into lesioned animals to see what would happen. And there were two things that happened. One, they survived, which we weren't sure would they be rejected, because actually we were putting human cells into animals. So we wanted to know, would they survive? Would that be a model that we could look for to see what happened? But the second thing was, we wanted to know, would they express anything, like a neurotransmitter? So in a neuron, the three constituent parts are, it has pathways coming in called dendrites, it has a cell body in the middle, and it has an axon, and at the end of that axon is a synapse where the neurotransmitters release. And we needed to know, could these cells in vivo, in the animal, release any transmitters? And they did. They did. And what we could see is that we could get behavioural changes, positive memory changes, by actually testing in animal models. And animal models were probably the most important thing at the time, probably not at all now, because actually we've moved way forward in what that looks like. That really took 3 years of my life to get that right. Getting the cells differentiated, getting them stopping from being cancerous in any way. But at the end of that, we were really in competition with 3 other large organisations. Cambridge, the professor, Steve Dunnett, who ran all of the big centres in Cambridge, examined me for my PhD, a big group in Sweden called Anders Björklund, and our group under Geoffrey Gray. My only regret is, at the same time, there was another group at the Institute of Psychiatry working on mental health disorders, and they got a Nature paper. So that was irritating because Steve Mitchell was on that paper. And I didn't manage to get a Nature paper at the time. I have one little thing that I was still more proud of in the end. But that was really quite mind-blowing. I then finished my PhD, and I was very fortunate that I was funded by the Wellcome Trust again to be a research fellow for them in this area. So that was fantastic, but I didn't read the letter very carefully, because the letter actually said you can't do it in the UK. They said that the best place for you to go is America. Bit of a hiccup, literally had submitted my thesis probably a week before I was then getting married. I was a very calm bride. And then I did actually ask them to defer my movement to America for 2 months, so got married in October and I went in January. And I went to work for an amazingly bright man. He'd worked at UCL for quite a long time, and I went to Bruce Wayner's lab. Bruce Wayner was reasonably bright, but what I did learn at Bruce Wayner's lab, that the genius was somebody called Eva Eves. And Eva Eves was world famous for looking at these cells and actually making them totally immortalised, that you didn't have to keep differentiating the cells. What she created was a cell line, so that every time you just wanted to be working with it, they immortalised those cells, and you did it by actually transfusing or with what was called then a heat-sensitive oncogene. I won't go into detail, so if there's any molecular biologists, I'm going it in a very simple terms, but it was another gene that actually made those cells not proliferate, but actually that you could keep repeating the cells. So that was pretty impressive, because it meant then we had a whole supply all of the time to look at, can we manipulate those cells to even more? Can we get more different types of transmitter releasing from those cells? The most important one was the cholinergic cells, and we used a cholinergic cell in this group called NS20Y. That cell line then was manipulated and put into an animal model again. What we could see was that actually we got even better results. We got even better improvements in functionality. At that time, worldwide, there was probably 5 groups by now, all looking at what was going wrong in Alzheimer's. The bit that we got wrong, and we still got wrong, was the cholinergic, the acetylcholine, the neurotransmitter, did die, wasn't released, and didn't allow people to have their memory. But it wasn't the trigger. It wasn't the trigger why people were getting Alzheimer's. We knew that if we gave some more cholinergic drugs or whatever, we probably can improve memory. But it is not the cause of Alzheimer's. It was a bit of a blow, but anyway, we still went on, and I was then went to work probably for the most scary man in the world. And it was quite amazing. I arrived at Rockefeller, and Paul Greengard said, "Hello, how are you? We're very glad you've come from England." And then he said, "And what shift do you want to work?" Oh my God, I have no idea what shift I want to work. So, and I sort of laughed actually, and he said, "No, I'm serious, what shift do you want to work? We have 3 shifts a day, and then on a Friday we all see each other's results, and then we'll see who's done the best. And then after that, if you've not done very well, you're on the worst shift." So he gave me the nicest shift, but I would say I did have the most beautiful flat in Manhattan. I could never afford that again, and I got a free phone. So that was really quite good. But Paul Greengard is a Nobel Prize winner. Died in last year, and probably made the biggest and the most significant impact on understanding how the cell works through different proteins. But at the time, what we were working on was, okay, we've got immortalised cells that we've been able to differentiate. And I might just use those words, and it might sound a bit complex, but my God, it was really hard to do. It was really hard to do, and we had to do a lot of work on it. But what Paul Greengard was interested in is how do we get the connections right? And he believed that actually the lack of connectivity, particularly in these neurodegenerative diseases, was quite problematic. And if we could make the connections better, by better release, by better connectivity, then we'd be able to understand these degenerative diseases way better. So I went with my NS20Y cells to Paul Greengard's lab, and we manipulated them with this substance, protein called synapsin 2. And we put synapsin 2 into these cells, and it's really interesting, these pictures probably would look so much better in 2019 than they did in 1996. But actually, what we can see here is that is the synapsin, and that is showing that by enhancing the synapsin, what we did see was better release of the neurotransmitters. So we put these products in and we got more release of the neurotransmitter. So it wasn't, again, going to cure it, but what we could do is get more of that neurotransmitter released through the synapsin, so that actually in the pathways or in the brain, you would be able to actually get better behavioural outcomes. And that was really hard work. I don't think I went to bed much of the time. What you realised is that actually everybody was on the same shift because no one wanted to go home at all. And so we were all fighting around the lab. But probably, again, working with somebody that challenged you, that asked you questions every minute of every day, that stood over your shoulder when you were doing some of your work, it made you become two things. You had to believe in what you did, but you had to be resilient. And you had to really, really understand that someone like Paul Greengard, his whole life was just in his lab. His whole life was about making a difference through research. So then we took a sojourn to Switzerland, probably not of my choice, but my delightful husband got a job over there. And this is when I decided I no longer liked molecular biology. So I went to Switzerland, and again, very well funded, the Wellcome Trust funded me, and I went to work at a place called the Friedrich Miescher Institute. And I sort of I still loved my neurons, and I was still very passionate about how were the way forward with cell transplantation models, but there were none of those in Switzerland. So I went to work for a guy called Andrew Mattis, who believed he did have the cure for Alzheimer's, and he believed that it was in a protein called microtubule-associated protein 2, and he believed that if we could understand that there would be a massive cure for Alzheimer's. But actually, as most of you have never heard of MAP2, we didn't have a cure. I came back from Switzerland and I went back to the Institute of Psychiatry. And the whole landscape had changed in 3 years. It had changed because actually we'd moved into just total fetal transplantations and into stem cell transplantations. And that is now mind-blowing. The opportunity for me with stem cell transplantation is really, really exciting. We've seen it in how people may be able to move their arms better through stem cell transplantation. What it hasn't really worked effectively yet on is in neural transplantation. We've not seen as greater outcomes. They did think there was a model for Huntington's disease, but it hasn't quite worked. But actually the concept, which I sort of feel quite part of, with understanding how we got to stem cell transplantation. But my other belief was, and I did find it really hard, was when I came back, before we probably moved straight into stem cell, was I was the person that had to go to the abortion clinic to pick up the fetal material. And I just had 2 children. And I thought, oh, I don't know if I can do this. And so not only did I feel I was no longer wanting to be in molecular biology, I did feel, oh, I don't know if that's me anymore. So I didn't continue. I sometimes regret that because I look at the advances in stem cell now. I look at some of our friends running companies with multi-million pounds that we were working with, but it was probably a decision that actually took me some way back into what am I really about? And what I did feel was I'd moved too far away from the clinic. I'd moved too far away from the people I was impacting. So this is mind-blowingly fantastic for me. Has had a huge impact on the science that happens today. Probably if I'd been in a different place at a different time, I might have moved in different ways with my research. But I probably now think that the last part of the story changed me quite dramatically, in that this was always very viable when you're in a world-class leading lab with the Nobel Prize winners, because you could see the clinic every day. But when you were just in a little lab, I didn't find it as close to that clinic. So I did then have a little break from work. I had my lovely children, and then I decided that I would probably want to go back and do a little bit of teaching. And you'll see on the slides, I did go to one of the most barking institutions in the country called TVU, and actually was renowned for being quite a hopeless place, probably one of the most loved places of my life, because it did allow me to do several things. But I was allowed by TVU to continue my research, and I was really privileged that somebody called Stan Newman said that he'd give me an honorary fellowship. So, as is the way, as academics, I did all my workload planning, looked at I could have these 2 days for research. It was absolutely fantastic. But then I was the programme leader and realised I didn't have anyone teaching on Tuesdays and Thursday afternoons. So, and this is where I am totally indebted to the lifestyle that we led, because I had to then get the train from Slough at 5:30 in the morning. I had to start work at 7 o'clock at UCL. I met the prof at 8 o'clock, and then I had to leave at 1 o'clock, get on a train to Ealing, run through the streets of Ealing, which I was probably well known for. People just used to almost like open their way. She's the mad woman's running through the streets, and give my lectures. But what I do believe is being at a university is about creating new knowledge, and I couldn't teach without creating that new knowledge. New knowledge is so important, because we can't be regurgitating what we already know. To have that new knowledge is the power of our new curriculums, of what we're delivering. So I did go work for Stan Newman. Again, it's just depressing that apart from Ingrid Halfyard, I've only got men that were actually at world leading, but they were all very impressive. Stan was probably the most difficult, and if he was here, I'd still say it, okay? Because he would never, ever, ever finish a piece of research. He'd always say, let's just go back and find something, let's go back and find what that means. But he did give me a huge opportunity, because I wanted to do clinical. I wanted to go into the clinical environment. I'd never been in that space. So he gave me a really, really interesting project. It's a self-monitoring project with patients with rheumatoid arthritis. And it was a really interesting project. Patients on a drug called methotrexate, which is actually quite a strong drug, have to have their bloods taken very regularly. And what we'd found in the UCL clinic was that people missed their appointments. People were not always getting their bloods right. People were getting ill because basically they just weren't monitoring bloods well. So what we decided was we'd set up a pilot to see if we could trust people to monitor their own bloods. So they could just go locally to their local GP or wherever, or their nurse or wherever that was, to have their bloods taken. But we would just send them the results and they'd make a decision, did they need an appointment or not with the consultant. And that was also, it would reduce consultants' time, but it was also about patient safety. However, we invited everybody in. There was about 40 people in this project, started off with 50 clearly, but 40 people kept on the project. And the first thing they said is, we've all paid our national insurance, love, and actually I want to see the consultant. And so it was a really interesting project, because I was thinking how exciting, everybody wants to do their own thing. And there was another side to it, that quite a large proportion of this population were probably over 60. And what I realised was it was actually their community. Coming to see the consultant, you know, we had one lady that she literally every month booked her taxi, went to John Lewis, had her pancakes, met the consultant, and that was her absolute lifeline. So it's really difficult when you're running these projects and you can't sort of see it always from that side. We were monitoring because we needed to look at what was patient safety. So we did this blood monitoring with patients on oral methotrexate, and we clearly wanted to look at whether individual differences about how people also engage with the programme. So we had all of these very high professionals that were on methotrexate saying it's a nightmare, I can't come and see the consultant, of course I'll monitor my bloods well, everybody over 70, they really wanted to come in, but they'll trial it because, and it was really interesting, they trialled it because they liked the consultant and didn't want to like Mike Shipley down. They didn't do it for themselves, they did it because they wanted to be supportive to their consultant. So, it was a 2-hour training programme, everyone was trained really well, and I did it with a really fun person called Anna Mandeville, who was a clinical psychologist, completely bonkers, often didn't turn up on time, but very reliable, and so we did a great project. What happened, and we did psychological measures, we wanted to know, in a way, how did people's belief about their medications, I suppose, lead to how well they performed on the task, and also we wanted to assess were there any other psychological measures, such as their own timeline, their own belief, their own concepts of the disease, would influence how well they performed on doing this task. And lo and behold, all my 70-year-olds were the best performers. They got all their bloods right all of the time, and all of my fantastic, high-powered, forgot to do their bloods, were all out of control, and it was a bit of a disaster in the first component. However, we did work with them, and we did over a 4-month period. The accuracy overall was at 85%, but what you can see is that most errors were in the first 2 months. In the 3rd and 4th month, there was 100% accuracy on people judging their blood assessment. And then the judgment of needing an outpatient performance was only at 80% accuracy. And that 80% accuracy was actually, most of them would ring you up. We were on mobiles all the time. They rang at all hours of the day. They'd ring you at 1 o'clock in the morning, whenever it was. But what we found was that wasn't that they didn't know if they needed an outpatient appointment or not. It was they wanted one. So it wasn't an error of judgment, but it was an error that actually they didn't want to just not have their appointment. The other bit that this taught me was that actually there was lots of stats on this project, and we proved that it was significant at 54% that this project worked really overall. But it also led me to think, okay, what happens to the 40-odd%? Because if it doesn't go well, that 40-odd% really, we're leaving them at risk in our community because they're not going to monitor themselves well. So it was a good outcome. Actually, this goes on now at UCL all of the time. They only run clinics every 6 months for people on methotrexate, and it's had a great, great outcome. What we did show was that people's belief and the importance of that medication to them led to how accurate they were in the study. But does it mean in a clinical environment that 54% of satisfaction or acceptance in terms of the statistical model leads to the best clinical outcomes. And I think that for me was quite a strong learning lesson. So, I did that for quite a long time, and after that I had lots of different projects. I had amazing PhD students. I had all of them now that I had post that project are now all professors. I had somebody called Caroline Lafarge that worked on a huge project around acceptance for people that actually had to have abortions with fetal abnormalities, and what did that look like. Really quite a scary project because there's not a lot of work done in the NHS for that. I had one of the biggest projects I worked on is with one of my close friends now, who was probably quite a demanding PhD student, somebody called Maddie Owl, and we ran a project which looked at students, young pupils that did not have opportunities at school. They were in the middle of their school band, they got missed, they got forgotten. And we did a big project which is now on the government listing for big projects called the Pyramid Project. But the biggest opportunity for now to talk about is, I came to Derby and I was a bit nervous as the Vice-Chancellor, was I ever going to be able to research again? And research for me is sort of in my blood. Research for me is who makes me who I am. Research for me is I would wake up every morning and listen to whatever is going on, and I'd want to know particularly the areas that I'm most passionate about, such as stem cells, such as behaviours, such as chronic disorders. And I was really fortunate that there was a project ongoing in the university. And the project was funded by a local philanthropist, Mel Morris, on looking at acceptance. Well, they were looking at personalised models of dialysis. And dialysis clearly is people that have kidney disease and it's not going well, okay? And so they need to go regularly for their treatment. The component in that project is we do very, very systematic approaches to how we deliver dialysis. It's all very regulated, it's all kept into metrics that are, you know, if the blood goes at this level, you wouldn't switch, you'd have to maintain everybody well. The personalised approach is everybody is different. And therefore, in that personalised approach, what we want is that actually we might be out of the norms. We might be looking at people that actually their blood doesn't need to be within a normal range. And so what that showed us was that actually it's a bit scary. Nurses find that quite scary because they've got to go outside of a range. But actually what we wanted to look at was how do patients accept that? And we didn't just do it in that patient group. And I have the PhD student, Carol Stalker, here tonight, who's just submitted, dead on 3 years, so that's brilliant. James Alander, who we've got loads of projects now working together, and a team from, and Paul Stewart, who's the professor here, but also Martin Tarl and Nick Selby from University Derby Hospitals. And this has been, I'm now actually using Carol's work, but as one of the key supervisors, this is what we're doing and this is what we're publishing on. And what we have really shown in this data is that we've done a longitudinal study. It is with end-stage renal disease people because we really couldn't be manipulating bloods on people that are not at the end stage. But actually what we're looking at is what factors lead to an acceptance both of the illness and therefore probably of their treatment. So what we can see in this study, and you don't need to really look at all of the elements, but if you look at the first graph, what we can see here is the acceptance of illness was the measure that gave the biggest significant proportion in physical quality of life. So if you've accepted your illness, you're more likely to do better, which is sort of common sense. But we have no idea why people were accepting their illness. We don't really know what acceptance quite means there yet, Carol, do we? We don't fully understand what that might say. In mental quality of life, what you can see is the purple is depression plays a very key role in that. as it does in kidney disease burden, which you again would accept as to be the norm. But what we need to really understand in this population is, particularly the ones that we've got a subgroup now that we're analysing, that we haven't done for PhD, but we're analysing, that we're in the personalised grouping. We've not got probably enough data to give significance, but what we want to know is in that grouping, that having a very different style of treatment, do we see significant differences? Because what we would like to be doing is understand what intervention would we actually work with those people so they have a better quality of life just by the style of which they are delivered dialysis. But there's no point in just saying that you might feel a bit better in terms of what your bloods tell you if you personally don't feel better for the treatment. And so the components of the relationship between the medical model and putting it with our psychological approaches means that we do believe that we'll be able to work on much more personalised approaches to medicine, which is probably what we will all be working on in the future. Each and every one of us probably in this room will expect a personalised model of medicine as we grow older. I don't think we'll be expecting that it worked with the person next door. I think we'll be wanting to know, what does it mean for me? And so the model that we've been using really shows that there are lots of other factors that influence maybe particularly the mental quality of life, which is clearly how anxious you are when you go and have your treatment, how confident you are actually. So self-efficacy plays a real significant role in actually how well you accept this treatment. And that also goes for clinical environment, the support of the consultants, and actually how you're supported. So this is the success really of James and Carol and the team at the hospital and Paul Stewart in the university. This for me is where I feel more at home now. I understand all of my medical approaches. I understand the medical models. I understand how chronic disorders all work. But none of the treatments are successful unless the patient or the person feels better. And so I don't think we can continue working on models that are just actually an answer that might work on you, because data doesn't show us that just by giving you a medical approach leads to successful outcomes for all patients. What it does tell you is that there is a real necessity to understand how a person will react to that treatment, and how actually, through looking at that personalised approach, we can get change and better outcomes. And although it might originally seem and sound an expensive approach, I don't believe it is, because we have so many people returning into clinical environments. We have so many people actually in and out. We have so many people not feeling better after their treatment. And so for me, it's actually, we do clearly, and I'm not in any way deriding, without medicine we wouldn't even be having this conversation. But what we do need to understand is, with the collaborative approaches between a very, very world-leading clinical group at the University of Derby Hospitals, and they are world-leading, Martin Thal is world-leading, that working with him, we should be able to see how we can improve the dialysis patients' outcomes. And so the team have won a grant. It's not huge amounts of money, but actually we've only been in this area in Derby for 3 years. And so we've got a 40k grant, and there's a whole team of us working on it. But this is to look at a model around acceptance and commitment. And so what we're looking at is, how do we tailor people's approaches to how an intervention model would enable people to, in a sense, accept, and therefore for us to be able to understand and get them to feel better through their treatment. It's a well-known model, James has worked on it before, but the component for me is, it's actually patient-centered. It's about how does the patient react and respond to how we're delivering their treatment. So I'm totally indebted to the team at Derby. I am totally indebted to lots of other people, and I'm just going to call out a few. I have got significantly other numbers of PhD students, and there are two people in the audience that probably don't even want eye contact with them, who are Dawn Foreman and Chris Brannigan, both professors, who every day come in my office and go, oh, we found 2 more people that are geniuses in the university, would you like to supervise them? What we do have at this university, though, are lots and lots of people that are now working on chronic disorders. We've got an outstanding member of staff who works in hepatology and actually has just written nice guidelines which have been accepted by the Royal College of Nursing for that treatment. I hadn't met her, and actually she's just stunning and is now going to do a PhD. Lots of publications, but we didn't know they were in Derby. And I've got David Robert Shaw, who's looking, which is a really interesting project, which was about Alzheimer's and dementia, but it was actually about how can we get information to people effectively through an online model. Again, the collaboration between something that's been very innovative at Derby through UDOL and actually using that platform to influence chronic disorders and engagement. So, my journey is a little bit erratic at times. My passion and the importance for me of knowledge creation is still the role of a Vice-Chancellor. But I think every day the important bit is how do we make a difference through the way that we as academics deliver and engage is probably one of the most powerful things that universities deliver. So I have lots of thank yous. Thank you, supporters, influencers, academics, collaborators, students, but particularly I've got my governing council here today. Thank you to them for allowing me still to be that person who wants to create new knowledge. Students and beyond. They're all my students, most of them, which I'm really proud of, are professors or beyond. And we've got people that hopefully will be professors of the future, and they're the people I'm still in touch with. And they're all the people that have influenced the journey that I went on tonight. Thank you very much.